Welcome to Get Moving TV. I'm Dr. Chris Landon. I serve as your host. We're going to have a special 56 minutes coming up. What we're trying to do is educate the physicians in our town, in our county, about chronic obstructive pulmonary disease. But I think that it's at a level where the entire community really needs to understand what's going on. We have some 28,000 people in Ventura County, and we know about maybe 3,000 or 4,000 of them who suffer every day from shortness of breath, don't understand why they just don't want to take the stairs anymore. What's come up recently is what's called World COPD Day, or Chronic Obstructive Pulmonary Disease Day, because this is a problem internationally. When I go down to the Honduras, what I see are biomass being burnt to try and keep down the mosquitoes for malaria. When we look at China, we've got all kinds of new market for tobacco. And with that comes lung cancer and permanent lung disease. So as we start off on World COPD Day, November 19th, what we're going to go over is we really want everyone in the community to learn, not just the physicians. So we're going to talk about what is COPD, what are the risk factors and the symptoms of COPD, what's the pathophysiology. This is a nice long doctor word, but what it means is what is it about the change in your own anatomy that causes these problems? What's the difference between asthma and COPD? Oftentimes I have patients come in my office and they have asthma and they were exposed to smoke years ago and want to know what the difference is. So we're going to talk about that. What are the global strategies in diagnosis, management, and prevention? And finally, how do we diagnose and assess it? So in this first segment, we're going to talk about COPD. Now, it's a common, preventable, and treatable disease. It has persistent airflow limitation, so there's an inability of air to move through your tubes. It's usually progressive, and it's associated with a chronic inflammatory response in the airways, swelling in the airways, kinds of cells that cause damage, and it's in response to noxious gases and fumes, like cigarette smoke, but also industrial waste, burning of biomass to keep away mosquitoes with smoke and fumes. Now what happens is exacerbations or made worsenings, comorbidities, so problems with heart disease, overweight, all these can add into the overall severity for patients. But all kinds of things go into it. One thing is, in the United States, there's about 100,000 people with alpha-1 antitrypsin disorder. With that, the onset of COPD is at a younger age, it's in the family, but mainly for us here in Ventura County, it's going to be exposure to tobacco smoke, occupational dust. We're in an agricultural county, so indoor air pollution. So we see this even more so in South America, where we see indoor heating. But in our poorer sections, in Oxnard, with farm worker housing, we may see heaters used indoors, exposing the children and adults to noxious gases. Outdoor air pollution is a problem. It used to be worse, but we think of Ventura County and particularly Ventura as being right up against the beach, but that airflow traps the smog. It affects our lung growth and development. Exposure to smoke even in utero while people are pregnant can affect your lung growth. Females tend to do worse than males. So if you've had this, you've been a female lung smoker, it's going to be a problem. Elderly, we tend not to see this disease until 45, 50, and beyond. Socioeconomic status, if you don't have access to medical care, and that's really what we're looking to fix, there's a component of asthma as well, and chronic bronchitis, so constantly bringing up yellow, purulent sputum. So it's a chronic problem, it's a progressive problem, sputum comes up, and this is made much worse with exercise. Chronic cough, much like I seem to be having now, can be intermittent and unproductive, or you may just be bringing up sputum at all the time. So when we look worldwide, it's the #1 cause of combined morbidity and mortality. People die, but every day their lives are affected by this disease. So it's divided really into two big parts: small airway disease. So as you look at our trachea, it's about the size of your pinky, breaks into 3 big tubes on the right, 3 on the left. Those tubes divide, 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 divide. And if I said divide 28 times, that's how many times your lungs divide. At the end are little air sacs called alveoli. And in those, if you can imagine a bunch of grapes, and the stem is hollow, those grapes are little air sacs in there. But what happens with this COPD is there's a breakdown in those grapes. So if you can imagine a little grape, that'll move a lot, you'll move a lot of air, but if it's one big one, it's really hard to get much air through. So what you see here is a normal alveolar wall, or that little grape, that final air sac, compared to what happens in emphysema. So you can see how thick that wall is, how difficult and narrowed that airway is. Asthma is different from COPD. With COPD, you can have asthma, but the kinds of cells that come out are different. There's an allergic cell that comes out in asthma called the mast cell. That's the main effector. Eosinophils, a kind of white blood cell, come out. And also kind of a response to the body called a CD4 T cell, as well as macrophages. When we compare that to COPD, that's mainly the neutrophils. These are the kind that fight off bacteria, and as they're pumping out hydrogen peroxide into your lungs. So if you've ever smelled hydrogen peroxide, you know that's not the best thing for any tissue. A different kind of cell called the CD8 comes out, and macrophages. Macrophages are running around chewing up the noxious, well, look at an ashtray. You wouldn't lick an ashtray. Well, that's what you're putting into your lungs. The mediators in asthma are different. Histamine is a major mediator. There's what are called the leukotrienes. The LTD4 is a big one, the interleukin 4 and 5. So these, it's a different set of molecules, and the treatment is different. In COPD, it's a more matter of inflammation, the LTB4, interleukin 8, and so the medications, which are very complex and ultimately expensive, it's different in COPD than asthma. So here we see the air trapping that occurs, so that narrowed airway leads to this expanded airway. So as you inspire, take a breath in, decrease the pressure in your chest, open up the airways, and then out it goes. While you see in COPD, there's swelling and the air gets trapped. So you feel this bloating, these blue bloaters we call them, because they're not exchanging air very well and the chest is big. As we look at the global obstructive lung disease measures, we have people who are at risk, people who've smoked for 10 years or more over the age of 45, and then those who start to have problems, whose air is starting to be restricted. And then finally, as we move along with more destruction from neutrophils and macrophages, finally, those are the people you see who are in the wheelchair and with the oxygen. The other problem is that our body then starts to fight itself off as well. So something called acquired immunity, the T cells and B cells are involved in continued destruction of the lung. So just the key points. So for diagnosis, we really need to ask the question, and you need to go to the doctor when you have these symptoms. Don't stay at home. We have things to make you more comfortable. Those symptoms will be dyspnea, a chronic cough or sputum production, and then exposure to risk factors in industrial or cigarette smoking. Now what we'll be doing is throughout the county, the clinics will be learning how to do spirometry. This is a test in which you take a big breath in and blow it all the way out. And with that, if there's a difference between the amount of air that you can get out in 1 second and your forced vital capacity, that biggest breath in to that biggest breath out, if that ratio is less than 0.7, then we need to do some more complicated pulmonary function. So we really want everyone over the age of 40, pack smoking more than 10 years, to be getting at least this basic screening so that we have an idea of how to attack this particular problem. So in summary, we've started talking about what is COPD, the pathophysiology, the differences between asthma and COPD, some of the risk factors and symptoms. We've begun talking about global strategies and the diagnosis and assessment.